end-of-life care, the costs and the quality. Tonight, On Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. It is something we'd rather not think of, but with today's medical possibilities, more of us need to balance our values, beliefs, abilities, finances, and family wishes when we consider end-of-life care. We're On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. In the 1960s, Jim Morrison, the lead singer for the band The Doors, was famously quoted as saying, "No one here gets out alive." He was right. We're all going to die someday. Much of what will happen on that day is out of our control, but our attitude, peace of mind, and the impact on our loved ones can be affected by the planning we do before that time. Tonight, we visit the difficult and emotional topic of end-of-life care. We are joined by Luann Eidsness, MD of the USD Sanford School of Medicine in Sioux Falls, and David Ziegler, MD of the Sanford Health Internal Medicine Clinic in Sioux Falls. Thank you both for joining us.
It's great to be here.
Yeah, glad to be here.
Tough issue. This is, and I said, we've got to have fun, but it's a kind of a sad topic, is it not? Tell us a little bit about are you in this kind of field?
Taking care of people at end of life?
Yes.
I worked as an internal medicine physician for a long time, but during that time I really liked medical ethics. And in the 1990s, the big focus on ethical issues were at end of life. Can we withdraw this ventilator? Can we stop these tube feedings? Who do we listen to in making these decisions? And I liked doing that so much, I gravitated toward doing hospice palliative medicine full-time.
And you are specialized in palliative medicine at this point. So you also, and also you're the head of the internal medicine department at the School of Medicine.
Yes.
So it's a great honor to have you here. Thank you so much.
Thank you.
And Dave, tell us a little bit about what got you into this area. You're an internist, a general internist like me.
Well, every doctor deals with patients who are dying. I mean, it's what we do, and particularly because I take care of a lot of elderly patients. I think some days most of the patients I see are over 90.
Yeah.
Which, we are living longer. And unfortunately, when you do, a lot of those people are more likely to die. And it's good to know what they want to have done. And I think it's important to bring up as a topic. And I see too many people not having a clue of what they want to have done. And a lot of physicians are reluctant, or they're so busy they don't get around to it. And so it's important for patients to have an active part in that discussion. So,
yeah. I mean, as an internist, we help them through this time of their life and the end of their lives. And unfortunately, I think you're right, that we don't see enough discussion between the physician and the patient.
Well, there's so little time, in that short time we have, 15, 20 minutes, half hour at most times, and you're so busy dealing with the high blood pressure, the diabetes, and all the other stuff that you don't get to some of the important things that you need to discuss.
Yeah. This is your topic. This is something that is so important for you to think about, and we'd love to have you call in, leave a comment, or let's ask a question about end-of-life care. Call us at 1-888-376-6225, or email your questions to ask@oncalltv.org. Thank you for that call. We want it. We need it. This is your show. So let's talk about the history of medical ethics and the end of life. I'm often reminded of Sir William Osler's article on the end of life in 1906, and he wrote an article and said that 90% of people end their life just kind of like how they came in. Gently, quietly, calmly, not awfully.
At home.
At home.
Yeah.
That 5% are elated, and then
Around their family.
and then 5% are in trouble. And then in 2003, they had a support study that looked at how people were dying now, and it was greatly different from that.
A lot of people
story.
die in the hospital, away from home at that point, and it was becoming more clinical, a clinical death, and they were much more controlled, but impersonal in many ways.
Yeah.
Well, away from family, we'll say life expectancy has improved though in that time.
True.
In 1906, 50 years of age. Ooh.
Yes.
Now 70s, upper 70s.
That study, though, showed that although we have all these advanced abilities to help people, ethics hadn't caught up, and we weren't really respecting people's choices. You know the support study. Tell us about it.
Well, even though people had advanced directives, and advanced directives is where a person can share what their wishes would be at end of life, it wasn't being followed. Maybe doctors didn't ask about them, or if they knew them, they were doing what they felt was right anyway. Or patients' families didn't. No, we want mom to be around. So yeah, we know in her document she didn't want this, but we're going to do it. But it was really the healthcare team that wasn't aware of the patient's wishes.
Right, and they also found that people were in pain 50% of the time, in a significant amount of pain.
Mm-hmm. Well, there's still some people who have a fear of pain medications. It's going to make me die earlier. What if I get addicted to the morphine? And so we still have a lot of education even now about that, but certainly
we hear that
10 years
a lot.
ago.
They're dying, but they're afraid they're going to be addicted to a pain medicine. I don't care.
Yeah.
We want to get rid of the pain for them and
Make them comfortable.
Make them comfortable. And people in those situations never get addicted to the medicine. They
No.
just don't.
They're on the end of their lives. This is not a thing that we need to be concerned about. One of the thoughts that I was thinking about in this was also that in parts of the country, people take care of people at the end of life different than in other parts. I think there's a lot of inconsistencies in the care in America. Now, what do you
and
think
it's
of
also cultural, too. I think certain cultural groups take care of their families. I think the Hmong are very much a family-oriented, caring for their loved ones out into death. I think it's different areas do take care of people differently, and I think it's partly cultural and what's accepted and what they've grown up and used to.
There was a surgeon from Texas that came to look at doing surgery at our clinic and hospital. And he said, "Gee, I looked through all your lists and I was just amazed. I mean, there's hardly any feeding tubes put in at the Brookings Hospital. Is there something wrong here? I mean, why aren't you guys doing that? I mean, we've got tons of them down there." And the answer I had was, you know, we have some feeding tubes, but we're pretty conservative about it. There's some differences in different places. What is your take on that kind of a difference as far as how people do feeding tubes?
You know, I think the feeding tube works really well when someone has obstruction of the esophagus, the tube from mouth to stomach, where a person needs nutrition to continue. But at end of life, artificially feeding a person who's in the process of dying, whether days, weeks, tube feedings aren't going to help. But we get asked, aren't I starving mom to death if I don't feed her? no. The natural process of dying is becoming more sleepy, having less appetite, eating, drinking less, and dying dehydrated is a very peaceful way to go. And it should be that way.
And the natural way of going.
Yes.
The way we did it for so many years until IV fluids and feeding tubes came into it. After 56 years of marriage, Florence Moeller lost her husband to cancer. It was a difficult time, to say the least, but her husband's hospice care program provided valuable support.
He had a prostate cancer. It was a very aggressive type, because ordinarily that doesn't give you so much concern, but this time it went quite fast. The nurse came, I don't recall now if she came every day, but anyway, often, and checked on how he was doing. And so he was here home pretty much in bed for about a week. They brought in equipment so he could have a hospital-type bed, which was a good thing, was more comfortable. That really was the most important thing right then, is to keep the patient comfortable, and she talked about that quite a bit, that we didn't worry about other things, but he needed that peace. Well, what happened was that I was unable to wake him up to give him his medicine and his pills and whatever he was supposed to take. So I called, and she was willing to come. I don't know, it was 8 or 9 o'clock at night, and I was so glad. It was such a help to have that support and that a trained person there. And then that was the time that we decided I really was not able to handle it after that. It certainly, I don't know if it works well for everybody, but it certainly was a big assistance to our family, to me, because I was the family who was here. But it was very, very supportive. I should say this too, because the staff certainly likes to hear that they are doing a good job. Chris was under treatment in Sioux Falls for some things and here for other things. And he said more than once that he felt the staff were just excellent as far as his care. He was very, very satisfied with the nursing staff, the doctors, and all of them who really took care of him, and he felt it was very, very good.
And what a wonderful man Dr. Moeller was. And thank you so much, Mrs. Moeller, for being willing to put yourself out there and share that important information. Hospice is really important. We should talk about that, but I want to point out that we need your questions. 1-888-376-6225, or go to oncalltv.org and push the ask button and give us your questions. Or you can join us on Facebook or Twitter and ask your questions as well. So hospice, are we, that's an added Medicare benefit, right?
Right.
Are we using it enough?
No.
Explain that.
Well, I first want to say I agree with her that the hospice nurse are the best nurses you can ever have. They are truly angels.
They are, aren't they?
They are the best people I've ever come across. I mean, you deal with them a lot, and yeah.
Yeah, and I'm on the, are you on the hospice?
No.
Well, I'm on the hospice committee, and we meet on Tuesdays, and it's just, I go in there just kind of broken from a tough week and a sadness of lost a patient, and they pick me up and bolster me and give me, it's a wonderful group and a wonderful thing. So hospice is something that we probably underutilize, though, am I right?
Well, in part, the reason we underutilize it is physicians have a difficult time with the prognosis, because Medicare hospice says a person can't enter hospice until there's 6 months of life left. So how do you figure that out? Well, for some diseases it may be easy. There have been studies where primary care physicians, general internists, family medicine, overestimate prognosis by 3 times. So people are hesitant to enroll their patient into hospice because what if they're not right? And yet the support of hospice is so great. you want people in a long time rather than just the last few weeks.
Right. I've expanded my thought. I figure, okay, they've got this. There's a significant chance it's going to be 6 months. Might be longer. We'll have to kick them off. But why not put them on there and have the added benefit?
And also, it's interesting, most of those nurses, they improve their care so well, they do live longer.
Yeah.
They do.
And
it's
you know,
amazing.
The hospice police doesn't come in and
No,
and
they don't.
get mad at
You
me
just
for
have to reassess and reevaluate.
Yeah.
Right.
I had a lady who was in her mid 80s with cancer that had spread all over her abdomen, and I put her in hospice. And she's my patient, lovely lady, and she got better. And at 6 months, I said, well, it's everywhere. We went another 3 months. She was just doing great, so I kicked her off of hospice. And 10 years later, she died of heart failure. You never know.
No,
you know what I mean?
you don't.
So we changed, but we should expand our deal and let people into hospice when there's a significant chance that they're on a dying process. And why not have this added Medicare benefit, right?
Do we need to explain what hospice is?
Well, what is it?
I'll let.
I'll go for it. Hospice is caring for people at end of life. And like we said, Medicare hospice says 6 months. But the focus on hospice is comfort completely. Comfort and quality of life. It's not just about dying.
Right.
I couldn't get my own mother in hospice until the last 3 months because she goes, I didn't want that, because she thought it was just about dying. So it is quality, it's comfort, it's support. I once heard a physician say that dying without the support of hospice is like having surgery without anesthesia. I mean, he felt so much about hospice.
Wow, that is a nice way to put it, isn't it? Well, and I think that all of the benefits, and plus they'll pay for some of the medicines. They'll get you beds. They'll be on call to support you through. I mean, it's a wonderful thing.
When I tell people, I say there's 3 things Medicare hospice will pay for: people, medications, and equipment. So the people are those nurses that go out there to the patient's home, social worker, chaplains, and then we have dietitians, physical therapist, the hospice medical director, but the people are essential. Then medications needed for comfort, so pain medications, bowel medications, something for nausea, and then equipment. So if a person wants to be at home and they need a hospital bed, bring a hospital bed into the room, or wheelchair so they can get out of the house and go to their granddaughter's baseball game,
Commode,
or whatever.
Whatever
All that
you
they
need.
need.
Yeah, the equipment. So, but there's a difference between palliative care and hospice care. I mean, no more chemo when you say hospice, so right? I mean, you're done with chemo.
Probably not. Some exceptions would be if the person's pain was tremendous and chemo would shrink the tumor and decrease the pain, or maybe metastatic disease to the bone and radiation would take care of it. So there's some exceptions, but in general, no treatment that would be focused on curative or life extension.
Right, and so that's the difference. Now, palliative how is palliative different?
Well, the same team of people, and the philosophy of that is still focusing on total pain and suffering, focusing on patient and family. But palliative care can start at the diagnosis of a serious illness, which may be life-limiting, and it can occur at the same time as aggressive treatment is going on. So maybe it's chemo, maybe it's surgery, maybe it's bypass surgery, but aggressive treatment's going on, and then as the disease progresses, the role of palliative care is more important, focusing on goals of care, and then back to the 6 months when hospice would kick in.
Right.
And so it's a longer period of time. It could be years before hospice.
Right. It seems to me that in times past, our whole mindset was cure, cure, cure. That's the support study again. They did not want to talk about quitting even when it was obvious they were going to die. They were going to die. Nope, we're going to still do full court press. And the palliative team says, time to let back, cut back on all that aggressive stuff.
Or at least just stop and think about what you want, what sort of life do you want to have, and what sort of quality of life do you have, and I think it's just good to stop and ask the patient, what do you want to have done? Do you want to have all this done? Or do you want to spend the rest of your money and your farm and all the savings you've had in the last 2 weeks of your life and with no hope of recovery?
And yet when you bring it up, it's the kids going, oh, we don't want to talk about that. Mom's doing fine.
Yeah.
Well, I think that's the biggest problem, is that the kids are full bent forward, and the parent, the elderly parent, would never want all of this, but they haven't talked with the kids about it.
Big problem.
So if there's a take-home message out there, talk to your kids about what your wishes are. That's the most important part. We've got a question here. South Dakota instituted the Comfort One bracelet program in 2004 for individuals who do not want CPR in the home setting. Where is the program? Why do the EMTs not know about this program? Why doesn't the public know about this program? Why haven't our South Dakota physicians supported this program? David?
We fully support the program, but I think I think people don't know about it. I think we as physicians need to inform people that this is an option that you can get. I think it's important to, and I'm not sure why the EMTs don't know. They should.
The EMTs mostly.
Mostly they know. They walk in, and that's part of what the first thing they look for is the bracelet. Yeah, Comfort One bracelet.
Which says no resuscitation.
Yeah. And
but it doesn't mean that you're not going to help them, you're not going to support them, they're not
well,
going to
and if they need to get up and get into the bed or get in a chair or whatever, they pick them up and help them, but they won't do CPR or, intubate and things like that.
Yeah. So we would say Comfort One, yay, and you want to know more, go to the South Dakota Public Health site. Wouldn't you agree?
Yes.
Mm-hmm.
We have a question in Rapid City. If the situation arises, how do I decide when to take a family member off life support? What signs do doctors look for when deciding if a patient is in an irreversible coma or declining and it's irreversible?
Boy, there could be several things. One would be multi-system organ failure, where a person's lungs failed, so they're on the ventilator. Their blood pressure may be low, so they're in shock, and they're on blood pressure medications. Kidneys are failing, so the kidney creatinine test is going up, and they're looking at maybe dialysis. And they're off sedation medications and still not waking up. That would be a poor prognostic picture. But sometimes it's very difficult. Sometimes there are people who have end-stage lung disease, emphysema, and they come in with pneumonia, end up on a ventilator, but their lungs are so bad they're not coming off. And that person could be alert.
Right.
And sometimes we have that person going,
take this out.
Yeah, and we have patients with severe COPD and or fibrosis of the lungs, and they know that and if you do intubate them, it's very difficult to get them off without them dying.
Right.
And they recognize that, but it is very, we can almost do too much.
Right. There's a time not to intubate. Although I had an 89-year-old gentleman who had pneumonia and had quite significant lung disease. I knew him. He wanted it. He wanted to be given the shot at it. Now, a year later, he's still at home. And so I'm just saying there's a time that you do. What about this pulling the plug on grandma and these death panels that was a big thing? Can you explain what that was?
well, they don't exist, for one thing.
There are no death
There are
panels.
no death panels. But they're referring to the discussion, because in that bill, they wanted to be able to reimburse physicians to have the discussion, and that's when, well, that would be a death panel. You're just going to take grandma off the ventilator. But it's not.
In other words, the government said we would pay doctors extra to talk about it. That was all, right?
And the discussion can be as short as, who do you want to make decisions for you if you can't, to, oh man, we need to talk about what your wishes are because you're not doing so well.
Yeah.
And that discussion can take an hour. And that's hard when you're having every 20-minute visits or 30-minute visits.
We still do. I didn't change anything that I do. I still talk to my patients about it. And, they advise me. I give them 3 questions. If you had a cardiac arrest right now and I thought I might be able to get you back, do you want CPR, yes or no? The second question is, if you've had a stroke, very unlikely you're ever going to know who your family members is and so on. Then would you want CPR, yes or no? And the last one is, and this is the hard one, and this is probably the most important, demented, don't know who you are, living in a nursing home, and you stop eating and drinking. Would you want me to keep you alive with a feeding tube? Yes or no? And those are the questions I wish that everybody could answer with their doctor.
One thing, though, it is important for patients to recognize is, though, although we have advanced the whole concept of critical care and CPR. Many people who have CPR, especially over 80, do not survive, or if they do, they don't do well following the CPR.
Right.
And
Over
long-term,
80.
over 80. And so it is important. You know, some people do, but the older you get, the likelihood of you surviving that episode drastically drops off. And so I think it's not like TV where people have CPR and they survive
And then they're fine
and
and
they're
walk out.
fine. And it doesn't work that way.
Yeah, no.
If you do survive, it's going to be a very long hospitalization.
Right. Well, I often think, okay, Joe, you're struggling with that question about CPR. Just think about it. That's the easiest, gentle, sweet way to go. Suddenly,
Yeah.
boom, you're gone. The other ways that we're going to die in the end of our life, there's oftentimes cancers. Sometimes it's Alzheimer's disease. Sometimes it's, ischemic disease to your legs. I mean, the best way to go would be that sudden cardiac death that we're reversing with CPR. Comments, Joanne?
Well, they've, of course, done studies on that, and 10% of the population will die suddenly, whether it be a sudden cardiac event or maybe a motor vehicle accident. So 90% of us, it could be 95% of us are going to know. We're going to have a chronic terminal illness where we will know this is the end. And the more I work with patients at end of life, there's advantage to that because people have time to take care of that business.
And say
the unfinished
goodbye.
business. Yes.
Yeah. Some people say it's grace.
It's a blessing. It
Yeah,
really is. That chance to say how much you love your parents or your child and say goodbye is essential. I think that ability to just be with them is invaluable.
Right. So so we put this death panel thing down, and we're talking about pulling the plug on grandma. That's all political hyperbole, right? I mean, there's no truth to that. You're right. No.
Yeah.
Right. So let's talk about the Terri Schiavo case, because that kind of is in that story. Tell us about the Terri Schiavo case.
Oh, I'm trying to remember how old Terri, but I think she's in her 20s, who had an arrest at home and wasn't found by her husband for some time.
It was kind of a suicide effort, maybe even, or...
I hadn't heard that, and I don't know that they ever found out why. But she was anoxic or without oxygen to her brain for a significant period of time and was in a persistent vegetative state. In persistent vegetative state, there are awake sleep cycles, so people have their eyes open, but there's nothing
going
up
on
here that's going on, and so people aren't aware. They can't communicate. They don't even look directly at you to know that you're there, and they're fed by a feeding tube. And for Terri Schiavo, her husband wanted to withdraw the tube feeding because he knew she wouldn't want to live like this, and her parents thought that there was some recognition.
Right, maybe there was a smile or something and all that stuff. And then there was the big fight. Well, who should be the one to choose?
Yeah.
And it would really be Terri. And the husband said, I know best for her. And
Well, and as husband, he would be her decision
and he
maker.
would be. And he did. But boy, he took a lot of guff for that. It wasn't long after that the Pope died. And there was also that same question. And he died gently. I mean, he wasn't dragged into a feeding tube. Any comments about that?
Nope.
Nope. Okay. Any thoughts about Terri Schiavo, Dave?
It was, I think the news media made more of it than the actual case. I think it was a difficult case for the family, but I think it became a media circus more than anything else. And I think that it's unfortunate when that becomes part of the decision making and not just the family itself. And unfortunately, she was young, and so she didn't have a advance directive, but it would be, that's why even young people should at least tell their spouse what they want to have done.
Right. I think young people...
I feel young, and I tell my wife, but I won't tell you what I told her.
Well, I think the idea of CPR, probably give her a shot if you think you can get me back. But if I don't know what's going on, just say that to your family. If I don't know, if this is your wish, you don't know what's going on and it doesn't look like it's going to be reversible, than no feeding tube?
Yeah.
I think that's an important question.
You know, there's some people who define life as a beating heart. So if my heart's beating, keep doing whatever you need to do to keep my body alive. I think the three of us would agree that for living, we need the ability to communicate.
Or recognize your grandchildren.
Exactly.
If I had some. I don't have any grandchildren. I'm sending a message out to my family here. No family, no grandchildren. Yeah, anyway. So that's another story.
Shameless ploy.
Well, yeah, and they're not married yet, but that's another story. But, okay, well, the Hopeful Spirit Chorale first sang at Christmas 2009. At that point, it was a men's group without the focus of singing to people in need. We sang to a friend during his last days, and the idea was born. Hopeful Spirit Chorale since then has been singing to patients in need of cheer. And as it turns out, we've fed our own souls all along the way. Come, come. There's a land that is fairer than day.
They did that while he was in the hospital, and he really enjoyed that. Yes, that was a very, very nice thing for them to do.
Hopeful Spirit Chorale is a group of kind of multi-generational people. We've got a lot of retired folks, a lot of folks who work, and then some college students as well. We meet on Tuesday nights and we practice singing, and then we go and sing to a hospice patient or an elderly patient or someone who just needs a little bit of brightening their spirits.
We shall meet on that beautiful shore.
Second verse, light.
Oh yes, a lot of personal satisfaction, a lot of camaraderie, not just with the patients but with everybody that sings, and it's a great group of people, and just there's a lot of age range, from college students to retired people, so I get to meet a lot of nice people and I talk with them, and we all get to go and do something nice for someone who's a little down.
Yes, I'm not much of a singer myself, but I've really enjoyed seeing the difference that we've made, especially for these people's families, because it's a really rough time for them.
Just so pleasant, such a pleasant experience.
It's not so much about the singing either, it's just about, giving up that hour every Tuesday and doing something for somebody else, and they really appreciate it, and I would totally recommend it.
We shall meet on that beautiful shore.
If you have any questions about end-of-life care, hospice, palliative care, call us at 1-888-376-6225 or email us on oncalltv.org or Facebook, or search the Prairie Doc Twitter. So give us your feedback. And we've got some good questions. That's a group of people, non-medical people, retired minister, college students, people from all walks of life singing for an hour every Tuesday night. Nice. It's the most joyful thing that I do all week, I have to say. A non-medicinal way to help people on the end of their lives. What other non-medicinal things do you think?
Well, it's interesting. A lot of patients in the hospital will have their own radio player, and they'll have a CD or something playing with their spiritual music or just hymns that they like, and I think that's really fun. And there are also people who come in and do prayerful meditation with them, different other techniques to spend time with them.
Mm-hmm. And there is actual music therapy where people will play guitars or harp, massage.
We've got a hospice, what is it, a harp kind of a thing. Mm-hmm. It's just they can play it at any time that they want. Animals.
Oh, of course, dogs.
Yeah. Dogs,
Great.
dogs, not cats. No. Biased or but no, but I think that, and I truly believe this, that churched folks, and not everybody's churched, but boy, this is a time that it's nice to have the support of your church to come around.
You know, and I have to put a big plug in for some of the ministers who come around to visit. They take time out of their busy schedule to come and visit the people in the hospital. What a wonderful thing for them to do.
Well, and it's truly helpful.
Yeah, it is.
I mean, it's wonderful help. So even if you're not a minister,
Yeah.
coming by to visit people. I know with cancer, people are reluctant to go visit them because what can I say? I don't know what to say. And the answer is,
Just say anything.
Say
Talk
anything.
about what's going on in your
yeah,
life.
hey, came by. Am I bothering you now? Can we talk? And then just let her go. Is there any methods by which a good Samaritan would be aware of an elderly person's wishes if found unresponsive? When in a surgery medical setting, does the DNR status always get recognized? So the first question is,
If
good
they
Samaritan.
had the Comfort One bracelet, it'd be easy to know.
Right, leave them alone.
If you come upon a person that doesn't have that, and if they're, I would always initiate CPR unless you know otherwise.
Right.
If they're all by themselves, you can never be faulted for giving care.
Right. Actually, we have somebody who has a better way of preventing this. We have a person who's been tattooed, and it says, "Do not resuscitate." Right there on the. Oops! Don't do it.
Well,
I
but
will
it's
say
below the
that's-
clothes, but that's the problem.
And that's not recognized.
No, that is not recognized.
It would not be recognized by most people, even though it's a statement.
Yeah, I would recognize it. I'd leave them alone. I mean, that's a strong statement. I would say this: you don't have to do mouth to mouth anymore either.
No.
If you just come upon somebody you don't know much, but just do rapid.
100 times a minute.
100 times a minute, keeping alive, keeping alive. So what about the DNR status? Then we just talked about that. How do you keep the ambulance team from going too far if you know the person does not want CPR?
Oh, that would be the Comfort One again, because the paramedics, when they come to the home or anywhere, they only recognize the bracelet or the Comfort One form. Otherwise, they're going to
do it.
They're going to do full CPR.
They won't. That's the group that won't recognize
Right.
that tattoo.
Correct.
But I would. Would you?
You like tattoos?
No, I'm not. So, my point is that's an advance directive. Don't do it. I had a patient who didn't want to be resuscitated, had end-stage heart failure, was pretty much suffering, but with it mentally. And then he had a cardiac arrest, and his wife called the ambulance. And the ambulance came and resuscitated him, and he was mad as a wet hen when he got awake, and he said, "Why did you do this?" And she looked at me and she said, "I didn't know what
panicked.
to do. I
You
panicked.
Yeah.
I'm sorry." And they were having a fight.
But that happens.
It does happen.
When you're in the short and your loved one is dying, what are you going to do? Well, you're going to call 911 because you're just panicked.
Right. You don't know.
And that's why it's important to have, first of all, the Comfort One. And if you don't have that, at least afterwards, you can make a decision to say, that's fine, but we're not going to go any further. And you can stop at any time,
Right.
too.
Don't call the ambulance if you know. Here's from Sioux Falls. My 92-year-old dad is slowing down. Do you need a specific diagnosis disease to be placed in hospice?
You don't. You have to document
don't?
decline. That we used to be able to use debility and dementia. Medicare determined a couple years ago that we can't, but we can still paint the picture of the decline. And so someone's not eating, they're losing weight, they used to walk around the block and now they can barely get to the bathroom.
failing.
They're failing. And we have to document that. There's actually a written narrative
Yeah, we
that
have to
has to
fill
be
out.
written.
You fill them out, too, don't you?
All
Yeah.
the time, of course. But I mean, if your doctor feels you're in decline and it's in a rough estimate, there's 6 months to live, it works. Viberg, how do you contact hospice care? Husband's very ill. The answer is you call the hospital and see where your nearest hospice is. They should know. The hospice or a nearby hospice or even a hospice.
Call your doctor.
Or call your doctor. Okay. T, ask about all three about end-of-life drugs, like the lady in the news recently going to
In Oregon?
Oregon. Yeah. What do you think of that?
I actually respect her own ability to make that choice. She knew that she was going to die. I don't want it for myself, but on the other hand, she knew she would have a fairly painful or difficult death after that, and so.
If you lived in Oregon, would you prescribe those drugs?
I wouldn't, but I know that it's.
You're
I can
not
accept that.
condemning him. Yeah,
no, I can accept that that was her choice, and that's what she wanted to do.
Yeah. Go ahead.
As even a hospice palliative medicine physician, I couldn't prescribe that medication for physician-assisted death. But we should also say it's illegal in South Dakota. It's only Oregon, Washington, Montana, and Vermont. But I, like Dave, can respect people's choice to do that.
Right. My father was really suffering. He had metastatic cancer, and he said, how am I going to get out of this? And I said, well, you'll get pneumonia, and we won't treat it. That's the old man's friend. Oh, and the next day he had pneumonia, or 2 days later, because he stopped coughing. And then he died the next day. And the point is, was that suicide?
No.
I know of a guy who I was talking last night. I was getting ready for the show, talking with a buddy, and he said, my dad had metastatic prostate cancer, and he was suffering. And he said, okay, how do I get out of this? And the nurse said, well, if you stop drinking, it'll be 10 days.
Yeah.
He stopped drinking, and he was gone in 10 days.
I think it's important to allow a natural death. It is a natural process, and people are so afraid of this. It's just like birth. It's part of who we are.
Right.
And if you allow it and naturally, it's actually can be a very beautiful thing. And people, it's sad, and the family will miss them, and they will cry and be sad, but that doesn't mean that it's not powerful and important.
Right, and the natural way that is probably the easiest, that allows the endorphins to kick in, is when they stop drinking and eating. When they stop that, they generally just gently, sweetly go away. And that's the way to do it. So IV fluids, no.
Yeah.
Well, and it actually can cause more harm because you're hydrating the body, and the congestion in the throat and in the lungs can actually.
It's actually more comfortable without the IV fluids many times.
When a person has a big stroke and you don't know whether you're going to get their swallow and you don't know whether they're going to recover or not, I think it's pretty easy to say, don't start IV fluids.
Right.
Let's let them get a little dry. Let the edema come down. Let's see how much we have. And after day 3, you see nothing left. It's a lot easier for the family to allow it to go
But
that.
it's that discussion you have with the family, though, so that they know what's happening. That's the important thing. And because family don't, they're on edge. They don't know what's happening to their loved one, and so it's important for us to give them some perspective as to what's happening and why it's happening.
The people at the end of their life need a doctor like you, Dave, to
Well, thank
help
you.
them through the end of their life. I mean, that's our.
Everyone should have that. I think
Everybody should.
have a doctor, and it takes time, and most doctors are. I think the majority of doctors in the state particularly are great at talking to their patients and respecting patients' wishes.
What is the advantage of surgery in end of life? What is the point of surgery when the prognosis is very poor? Well, there's time for surgery. Broken hip, for example.
Yeah. I've had 95-year-old or 90-year-old women who've broken their hip, and I recommend they go for surgery to repair the hip because otherwise it's painful. And so I think it's good to go ahead and treat that. That doesn't mean that you're not respecting their wishes for DNR, but I don't think fixing a broken bone is the same as keeping people alive artificially.
Right.
And I would say it depends.
It
because
depends,
if
too.
someone is fairly vibrant still, fixing
I
that
think
broken hip
it's
may be
true.
very important. On the other hand, if they're so in decline that you expect weeks to months anyway, you're going to keep them comfortable
That's
with pain
true.
medication.
I've
Just
done
do
that
the
too.
pain.
Yeah.
It depends, doesn't it?
It does.
And by the way, I didn't mean that I wouldn't want you as my doctor
I
either.
know.
I was making that point, But you're head of the Department of Internal. You're too busy.
Oh, jeez.
The other thing about surgery, if I may add, and a DNR doesn't mean don't treat. We have so many
Right.
people, doctors included, who see a DNR and go, oh, well, I guess we aren't going to do anything. No, it doesn't mean that.
No.
It just means no resuscitation at end of life, but if there's a bowel obstruction, it may be
Treat
very
that.
appropriate.
Antibiotics,
Yes.
Yeah.
whatever you need to do to treat,
Sometimes, though, at the end of life, and they're declining, and we're ready to go, it's okay not to give antibiotics.
That's true too. I think that discussion's important.
Yeah. Belfouche, 84-year-old man. Do you know anything about the alert system bracelet? Well, that's it. This is the
Comfort
One bracelet. Call the state health department. It's in your phone book, or go to the internet. Sioux Falls, 50. Okay.
So I'm going to interrupt because the Comfort One form, a person can't order it themselves. They do have to get it through their physician's office.
But you can get the form, put it to your doctor.
No,
I don't think they'll send it to people. I may be wrong. I'll stand to be corrected there,
Okay.
but I think they have to get it through the doctor's office.
Find the details, though, at the state health department.
Yeah.
They'll inform you. Thank you for that. But are there other bracelets? You know, there are bracelets that you can have.
That aren't they aren't legal though. I don't.
Yeah, there's Medic Alert bracelets, and he mentioned alert, so that would give indications for allergies. But for Comfort One, which is the out-of-hospital do not resuscitate, it's a specific bracelet.
So if you want do not resuscitate, it'd be reasonable to get the Comfort One. Go to your doctor, ask for it. Well, if the doctor doesn't know, then connect him or her, with the state health department. Do you have advice for a nurse working with a dying patient currently receiving chemo that wants to stop but the family does not? Ooh.
Yeah.
You tell me.
Not an unusual situation. My recommendation would be to get the patient family together with either the family physician or the oncologist and get it out in the open, talk about it. And we do respect patients' right to refuse treatment or to stop treatment.
If the patient is competent, that patient can say no, and that's what goes.
Yes.
Right. We have to follow what the patient wants to do.
That's right. It isn't the family's
no.
choice, it's the patient's choice. And you know, that patient probably has a primary care doctor that you can talk to.
And I understand what the children are going through because they care and love their mother or father very much, and they don't want them to die. But on the other hand, they should also look at it, do they want them to live in pain or in a situation that's not tenable either?
Right. Now, if that patient isn't competent, right, is demented,
Then it's become
Should we be giving them chemo for
unless they've
cancer?
written down their, what you be giving them chemotherapy too if they're not.
Yeah.
Sioux Falls, what are your opinions on physician-assisted suicide? I guess I haven't said my opinion. I'll give you my opinion. I do not feel that it's right for me to give a poison or to inject a poison or to prescribe a poison for purposes of killing a person. I just think it changes the doctor.
Right.
Now, will I inject enough morphine that would kill the person prematurely maybe when I see them uncomfortable? Well, yeah. I mean,
Well, your intent is to take care of the pain, though.
Intent.
It's all about intent.
bingo. When is the time for someone to go to hospice? What are the signs to watch for? Hospice. What are the signs for hospice? It's that probable 6 months.
Yeah, and I think if they're suffering and they need more pain medication, if they need additional nursing care, that's the time when you need it.
Let's be liberal with it. It's an added Medicare benefit, for goodness sake. If you might qualify, why not try to get it? Push your doctor. Here's from Rapid. Please discuss grief counseling that's provided by hospice. It's provided by Medicare for family members preparing to deal with the death. That's the other thing I wanted to make.
great.
Hospice helps the family through all of this and for a year after the death.
And anticipatory grief also. The grief support doesn't happen at time of death. It starts prior to death and then continues for that year.
Right.
Grief counseling is extremely important. It's one of the best things they do.
And how would you describe it? I mean, grief counseling, I think what it is I care, you're not alone. and share with
I
other
think
people?
just support and having other people around that understand what you went through.
All right. 70-year-old caller, very depressed, doesn't want to continue living. How does she make sure her living will is observed? Should she send it to anyone besides her durable power of attorney who lives far away? And my answer to that is talk to everybody who is going to be there for you at that emergency room.
But also, she needs to have someone talk to her about the depression and treat the depression.
Mm-hmm.
If at 70 years old,
You've got some years to live.
you need to treat the depression, because sometimes that's why people get to that point where they don't want to live any longer. And
Yeah, even in hospice we treat depression.
we do.
Well, I think it's important, not only with medication, but grief
Counseling.
support and counseling and the whole 9 yards. We'll be right back after this.
But what if Mary comes out of the coma?
I will forever be with you, even if she walked through that door right now.
How's it going? Yo.
You never know where you'll find the flu bug hanging around this time of year. Get vaccinated. It's free for children 18 and under, because stopping the flu starts with you.
What happens after we die? Of course, that's the great mystery about which every religion has wrestled since the dawn of time. This short essay will not have the answer either, but as a physician who has experienced a lifetime caring for people, I have some observations about fearing death. Although it must be a survival advantage taking precautions to avoid danger and an early premature death, I have watched how the fear of death can sometimes bring it on. For example, one woman observed a relative with cancer suffer a miserable death. Because of her fear of a similar fate, the woman avoided appropriate and effective treatment for her own breast cancer, resulting in a premature death. I have also watched how the fear of death can sometimes greatly reduce the joy of life during the time that they had left. For example, one man with the diagnosis of cancer sank into a black hole of funk and sadness so deep, he avoided visits from his family who loved him and eventually slipped away still immersed in fear and regret. Whether young or old, and especially during this concentrated time at the end of life, I have seen how the fear of death is not only dangerous, but also reduces the quality of life in the end. So why does this happen? Is this because humans do better embracing a hopeful spirit? I know we like a happy ending, not a sad one. Of course, a hopeful message about death seems to make it easier to help people and their families who are facing death. But does being hopeful mean we have to pretend it's not going to happen? I have watched folks facing death with courage and hope by fixing unresolved issues and regrets, expressing and embracing their love for friends and family, savoring the moments of time that they do have left, enjoying a sense of humor, and being thankful for the blessings they do have. And then when death finally happens, they greet it with ease. If you or someone you love is facing death, I recommend the book Final Gifts by hospice nurses Callanan and Kelly. Their words give great comfort about the dying process. Although what happens after we die is beyond understanding, the dangers of fearing death should be a lesson to us all, whether or not we know our own timetable. By facing death, we are better prepared for life. This brings us to the end of our show this evening. I sincerely thank our fantastic guests tonight, Dr. Luann Eidsness and Dr. David Ziegler. Mark Twain could have been a guest on our show tonight. He said, The fear of death follows from the fear of life. A man who lives fully is prepared to die at any time. And until next time, we want you to stay healthy out there, people. And thank you, too, so much for joining us.
Well, thank you. It's great to be here, Rick.
There we go. Okay. Well, we have a picture.
Oh, the weather outside is frightful. What are the special concerns for those of us who live where winter visits with an enthusiastic vigor? Next time on Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer some of the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you, and thank you for the questions. Here's a comment about Comfort One. You can get a Comfort One form by SD South Dakota EMS online on the South Dakota Department of Public Safety, and it requires a signature of the patient and the physician, PA, or nurse practitioner. Did you have the online site?
Yeah, it's www.sdemta.org.
Okay. So here's from Sioux Falls. Where do you get the Do Not Resuscitate bracelet? And the answer was the Comfort One information has been put on the Prairie Doc site. Go to oncalltv.org or go to the South Dakota Department of Public Safety, or call that number 605-773-4031. Great. We've not said enough about Comfort One in these years. Here's a comment. This morning after my husband was placed in a nursing home, he told me the bed was horrible. I told the hospice nurse when she came, and the next day there was a wonderful new comfortable bed, which he appreciated very much. He could talk to the hospice people in ways that he couldn't talk to family. He passed away after 2 months and 10 days. Within just minutes of a wonderful hospice volunteer conducted a sending ceremony.
Isn't that nice?
Here's a caller from Brookings. Address end-of-life care for low-income and homeless. Are they getting access?
Oh, that's going to be hard. I think all the hospice programs do provide care to the indigent who don't have insurance. But is it the same? Is it enough? We could do more.
We could do more. And in this state, we don't have coverage for the people who are above poverty but below this gap that we have, unfortunately. Any other comments, Dave?
No.
Talk about hospice for different kinds of patients, like cancer versus patients with Parkinson's or dementia.
Mm-hmm. You know, half of the patients in hospice have cancer, but the other half have end-stage whatever disease, and it could be end-stage Parkinson's. It could
Severe
be any other
Alzheimer's, recurrent pneumonias.
It's having a terminal illness with a life expectancy of 6 months, so anyone
Heart failure.
can come into that heart failure.
That's right. Could home health care be an option compared to hospice?
Boy, it's pretty limited, and the requirements with home health care is you have to be homebound, and with hospice,
you can't you can't go to church, you can't go out for dinner, you can go see your doctor.
Right.
But that requires that you're homebound. That's the problem with home health.
Yeah. And it's different.
And it is.
Yeah.
You will get more support through hospice.
Yeah.
Right, so if you're anywhere close to qualifying, you want to go to the hospice route. Winner, 59-year-old man. Caller recommends a book called Being Mortal by Atul Gawande.
Yeah, it's a good.
Tell me about it.
Well, it's on my to-read pile, but the people who have read it really like it. It's stories. Dr. Gawande has done a lot with safety, patient safety and quality. And he writes this, I think, in part by his own experiences and his family. But yes, it's a must-read from what I hear.
Have you read it?
It's on my book too.
Yeah. So I'm going to put that aside and say I'm going to buy that book and read it. What is the rationale for Medicare not paying for room and board at hospice care facilities? Do you understand what that question is all about?
Yeah, because Medicare hospice pays the people, medications, equipment, wherever the person is, whether it be home, nursing home, or a facility, but they do not pay room and board
at a nursing home, for
anywhere,
example,
or a hospice
And
facility.
They don't pay for that period. So.
Right.
And I think part of it's just financial.
Yeah.
Just think of how much that would cost.
Yeah.
Right. So yeah, but it's like going to the nursing home, but you get extra. People who are in the nursing home, for example, I just put someone in hospice who is in the nursing home, and the family looked at me, and the nurse went, "Oh, what a plus it is for them, because it gives us help to do the things that we need to do, but just the added special care." So it's a good thing. Who's the best person to appoint to make decisions for you for power of health care? Are spouses or partners necessarily the best ones, or are they too close? That's a great question. Power of attorney.
Very good, yeah.
Let's talk about power of attorney. What is the durable power of attorney anyway, David?
Well, durable power of attorney is basically a way to legally write out what your, first of all, who will make decisions for you if you're incapacitated and unable to make those decisions. And I think that you want someone who's going to be available and able to make those, whether it be a child or a wife
Sibling
or whatever,
or
sibling, whatever. But I think it's someone who's going to be around and who has the, in some cases, the knowledge of what you want to have done.
Right.
I think that's the most important thing.
Yeah, well, I just tell people, find someone you trust.
Yeah.
Trust, and they will honor your wishes, but then don't just hand them the document, talk about it. So
Right.
they really do
They
know
know
your
what
wishes.
you want. Well, and of course, you know, I've got this old guy said to me, I've got a daughter who is just a absolute, loves me and would do anything for me, but I wouldn't drag me through everything to keep me alive, when the son would let me go when I need to go. And so he's going to be my durable power of attorney. And I'm going to have her be my financial power of attorney, so that they're not connected.
And they're two different things.
Yeah.
A financial power of attorney versus a durable power of attorney.
For healthcare.
For healthcare are two different things.
They don't have any power until I have lost my capacity to make legal decisions. Right. So that's a great thing. Any take-home messages that you want to make sure that we talk about? I want to make absolutely sure that we say clear as a bell that when you don't put a feeding tube in, and if a person is unable to take food, even if you put it up to their lips, or food or water, to let go and to let them not have food or drink is not forcing them to a suffering.
No. The other thing I would like to point out is, you know, I've been present when a number of people have died, and it is not scary. It's very peaceful, and it's a very privilege to be with them and during that time.
Holy place.
It is a holy place, and you know, people are afraid of it, but it's not what you think it is. And I think it's embrace it and embrace them, and especially while they're alive. And it's a mystery that we all need to be aware of, and also society needs to be aware that this is part of a mystery of life and death.
We're fearful of death.
We are.
I think, and I don't know whether it's our society. You know, the Eskimos weren't. They go out on an ice floe. Time for me to go.
I don't think they do that anymore.
I don't think they do. Comment about fear of dying?
Oh, it's there, but we got to talk about it. And I think that's one message that we have is talk. You got to share your wishes, because it's a burden on family if it's not talked about. And talking about death isn't going to make it happen.
No.
But we do need to share.
Yes, we
share
do.
what our wishes are.
Well, thank you both again so much for being on the show and sharing your knowledge. And thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at our regular time. Call in or email your questions, and watch for a Prairie Doc Perspective column on your local newspaper. Listen to your Prairie Doc Conversations radio show on a station near you, and follow us on Facebook, Twitter, and Pinterest. Next week is all about winter health. It's a call-in for any question. So until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.